Good afternoon, everyone. I'm Stacey Sennett, Program Director at the National Kidney Foundation, serving New England. I would like to thank everyone for joining. As we wait for additional attendees to join the webinar, I would like to take some time to go over some features you can utilize during our presentation. All attendees have been muted, and for any questions, please use the Q&A window. The Q&A window will allow you to ask questions to the presenters. To locate the Q&A window, hover your mouse over the screen. Click the Q&A tab. Once open, you can type in your question into the Q&A box. Click send. The speakers will then answer your question live after the presentation. We can't promise all questions will be answered due to time commitments, but we will do our best. We would like to thank our sponsors whose educational support has made this program possible. Again, thank you for joining this afternoon. I would like to introduce Medical Director of Kidney and Pancreas Transplant Program at Brigham and Women's Hospital, Dr. Chandrika.
Well, thank you very much, Stacey. I see people are still joining us online, so we will wait just a minute to get the program started. I'd like to thank everybody for joining us. This is part of a regular series of webinars that we have between Brigham and Women's Hospital and the National Kidney Foundation, where we discuss clinical issues for patients with kidney disease and kidney transplantation. We hope that this gives patients and caregivers an opportunity to listen in on interesting and updates on kidney disease, but also have the opportunity to interact directly with speakers and ask questions and get to understand more about our programs at the Brigham and Women's Hospital in particular. So it is my great pleasure to introduce our speaker today. After our speaker has finished, there will be a panel discussion. But I will introduce the panelists first, and then I'll introduce our speaker. So we're very fortunate today to have a number of very prominent physicians and a surgeon in the area of kidney disease and kidney transplantation. Our first panelist is Dr. Velmas Cattleberry. She got a medical degree from Columbia. From Columbia. And she's previously a professor of surgery and assistant dean of community education, as well as the director of transplantation at the University of South Alabama. She's also written a book entitled Beyond Every Wall, which outlines her experiences on becoming America's first Black female transplant surgeon. Our second panelist is Dr. Edgar Milford. Dr. Milford is a graduate of Harvard Medical School. He's director of the tissue typing laboratory at the Brigham and Women's Hospital. He's a past chair of the board of directors of the New England Organ Bank and chairman emeritus of the board of directors of the National Bone Marrow Donor Program. Our third panelist is Dr. Kevin Tucker. Dr. Tucker is the vice president for education across the Mass General and Brigham and Women's Hospitals. He was previously the nephrology fellowship director at the Brigham and Women's Hospital, and has also worked as the director of the dialysis unit at the Faulkner Hospital and as a clinical nephrologist. Our speaker today, I'm very proud to introduce Dr. Wynn Williams. Dr. Wynn Williams, I count as a very dear and old friend. He's the Associate Chief of the Massachusetts General Hospital Division of Nephrology and Associate Professor of Medicine at Harvard Medical School. He's also the founding director of the Massachusetts General Hospital Center for Diversity and Inclusion. He received actually the Harvard Medical School's Lifetime Diversity Achievement Award in 2015. He's being honored at the National Kidney Foundation's New England Honors event on March 20th as a most outstanding nephrologist with a lifelong contribution to the discipline of nephrology. And most recently, he was named as Deputy Director of the New England Journal of Medicine, a very high honor indeed. And it was the first African-American physician to be appointed to this position in the history of the journal. So with that, I'm going to hand over to Dr. Williams, who's going to give us his talk. Then there'll be a panel discussion, and then there'll be an opportunity to ask questions of Dr. Williams and the panelists.
Well, Anil, thank you very much for that very warm introduction. And it's my pleasure to join this panel, my esteemed panelists, to present to you this afternoon. Can everybody hear me and see the screen well?
Yes.
Great. Well, I'm happy to be here. And so our job today is to share our insights on challenges for kidney transplantation regarding health disparities in CKD and kidney disease and transplantation as a focus. And all of our panelists have been experts in this area for really these many years. And I've had a 25-year experience with transplantation myself at Mass General Hospital. So I hope to take you through a tour of some of the prominent issues that have come to the fore in the past year or so, and indeed have been with us and challenges for us for the past 25 years. So without further ado, I have no disclosures. So I can start here. Acute and chronic kidney disease, I don't have to really remind this audience that it represents a worldwide public health problem. There's variation in incidence, prevalence, and outcomes by race, and it may reflect differences in geography, race, ethnicity, and genetic ancestry. There are biological factors that actually may contribute to disparities. There's recent focus on the APOL1 gene variation in African Americans, which affects about 10 to 14% of African Americans in the United States. The genetic variants of APOL1, G1, and G2, when they're homozygous in African American candidates, can confer an increased risk of CKD and end-stage renal disease. Socioeconomic and behavioral factors also factor into disparate incidences of kidney disease, CKD, in ethnic minority communities, so-called social determinants of health, and then access to and the quality of healthcare also are very important factors in terms of risk. To remind this audience, and some of you don't need to be reminded about this, the overall incidence of end-stage renal disease in African Americans is 3.5 to 5 times that of white individuals, and African Americans constitute about 1/3 of the dialysis population in this country. Non-diabetic kidney disease afflicts Black patients disproportionately, and in one study, this is from a Hopkins analysis, the rate of nephropathy associated with HIV infection among Black patients was some 50 times that of white patients who were similarly afflicted. And of the more than, again, 500,000 individuals with end-stage renal disease in the United States, more than 1/3 are Black. This just shows you the growth of prevalent dialysis and transplant populations in the US. And this is as a result by dint of Markov modeling. And this gives us an analysis looking at projections that began in 2006 out to 2020. And you can't see the dotted lines here that are overlying the solid lines, but this shows that the modeling is exactly fitting the linear progression here in terms of the dialysis patient counts in 2020, over 500,000 patients, and similarly in terms of transplant prevalence, over 250,000 patients out to 2020. And so the idea here is that these curves are inexorable evidence of increasing end-stage renal disease and the need for renal replacement therapy. If you look at in terms of health disparities in renal disease, racial disparities in the quality of and access to care for patients with kidney disease are well documented. They've been well documented now for over 30 years. Compared to white patients, fewer Black patients with CKD are under the care at end-stage renal disease of a nephrologist. Their rates of referral for peritoneal dialysis and kidney transplantation are significantly lower. Black patients who receive dialysis are less likely to have had upfront, timely dialysis preparation. For example, the placement of AV fistula or AV grafts for dialysis access. They're less likely to have achieved target hemoglobin levels before and during and after dialysis is initiated. And after dialysis initiation, less likely to achieve adequate dialysis dosing. And these are all metrics that are associated with a decrease in dialysis survival. Now, when I was a fellow, there was teaching about who does well and not on dialysis, and there's a notion that Black end-stage renal disease patients did better and had a survival advantage on dialysis and should remain on this modality. And this was widely touted in the literature. Prominent among analysts was this publication from Larry Agadoa and Paul Eggers from the NIH, and they suggested that the risk of death was nearly 45% lower in African Americans than Caucasians undergoing dialysis. And they made the editorial comment that in light of the higher mortality rate in African Americans in the general US population, this paradox required further investigation. And in fact, an investigation was forthcoming with Dori Sega's group at Hopkins with Kasurka, where they looked at an observational cohort study of about 1,300,000 incident end-stage renal disease patients captured in the United States renal data system, the USRDS, for about a 15-year period from 1995 to 2009. And what they showed is they look at the association of race and age with survival among patients undergoing dialysis. Now, the next slide is a bit complicated. I'll take my pointer just to show you the salient features. This is looking at incident ESRD patients who died on dialysis as recipients or who received a transplant. And in the left panel, the whole point here is just go along the left column here. And as you get beyond the age category of 50 to 60, down now to 18 and 30, you can see that the relative risk of those patients who die on dialysis increases from 1, the reference, to 1.2 to 1.4 to about twofold increased relative risk of death on dialysis if, in fact, you're in this black column, a Black patient. And similarly, in terms of rates of transplantation, just to the rightward column here, the relative risk, you're half as likely if you're Black to be transplanted in relation to white patients on dialysis. So what is the best renal replacement therapy? You're coming to a slide that I'm very happy, very proud to show you because it's the work of our colleague on the panel here, Dr. Milford. And this is a similar contribution to the transplant best practices, where he and his fellow co-investigators, Bob Wolf, Fritz Port, and others at the University of Michigan, published this analysis in the New England Journal 20 years ago in 1999, looking at the death risk of remaining on dialysis as compared to transplantation. And what you see here is on the y-axis, the relative risk of death. Mortality is high in this dotted line for transplantation. Immediately post-transplant, about a threefold rate of mortality related to surgical transplant misadventures, wound dehiscence, infection, bleeding, and so forth. But after 106 days, the risk now crosses the line of reference at 1 here. And so if you have a well-functioning, durable kidney transplant, now you have a survival advantage that begins after 106 days post-transplant and is durable as long as that kidney is functioning well. And again, this was a seminal contribution, so that now we say that for nearly all waitlisted chronic renal failure patients who are predicted to live longer with a kidney transplant than staying on dialysis alone. Not only do they have a better quality of life, being rid of the necessity of maintenance hemodialysis or peritoneal dialysis and the complications related thereto, but also an increase in longevity. So in a perfect system, we would just take a kidney off the shelf and immediately implant that kidney in a patient with end-stage renal disease. And to do that, the required condition would be that supply would far outstrip demand. But we know, in fact, that that's not the case. That if you look at the actual conditions for allocation, the waiting list in pink here is really huge for all organ transplantation. About 90,000 patients in the United States are awaiting kidney transplantation. We have about 17,000 kidney transplants a year. So demand actually far outstrips supply. And our challenge is to allocate a resource where demand does greatly exceed supply. It's a scarce resource, and we need to make trade-offs based on values and guiding principles. And the allocation principles here by OPT and final rule that allocation be based on sound medical judgment, achieve the best use of donated organs, avoid wastage, wasting organs and futile transplants through objective and measurable medical criteria, but has to be balanced from this utilitarian concept of the most transplants for the majority and the most efficiency by a principle of justice, that patients who are vulnerable, who are who have lesser health literacy and such, also deserve a seat at the table and the opportunity for this best practice. So what are the barriers to transplantation? Many of you they're well known to many of you: lower level of educational attainment, lower health literacy on that basis, lower socioeconomic status, non-English speaking background, minority ethnicity, and even women in general, dialysis in for-profit or isolated units, certain medical diagnoses, although they are rare, and then the epidemic of obesity. This is data from Andy Epstein and John Ianian at the School of Public Health here at Harvard, looking at barriers to transplant. And these are tiered barriers in 4 large geographic areas in the United States. And they looked at the idea of you've got to get to the wait list, and to get to the wait list, first you need to be evaluated before you can receive a kidney transplant. And so what they showed here is that in relation to whites, African Americans had about an 8% decrease in the relative rate of referral for evaluation in the first instance. The second tier, being placed on their wait list after evaluation, there's about a 15% difference delta between if you're white, 87% thereabouts, and if you're Black, 71. But if you look at those patients who went on to get first transplantation, the opportunity to actually realize a kidney transplant, there's a fully a 35% delta between those patients who are white and those who are Black. So there's a very deep disparity in those who realize the opportunity for kidney transplantation. These are data from Emory with Rachel Patzer and Nancy Kuttner, looking at young Black patients who are looking at the association of race and insurance type with delayed assessment, delayed evaluation for kidney transplant in the United States. And what they found is that, in fact, if you're in the 18 to 34 category, a young Black patient was much less likely to be presented the option of transplantation around the time of starting dialysis. This looks at the odds ratio for being reported as not assessed for transplantation at an odds ratio of 1.27, a 30% risk of not being referred. So why are these topics now continuing to make the news and come to the fore? And I think part of the emphasis of looking at health disparities are really the deep health disparities that have been unearthed, that have come raging to the fore in the wake of the COVID-19 pandemic. And also there's been a renewed effort in the aftermath of the racial reckoning over the past year and the broad public outcry after George Floyd's death in the spring, his murder, to address systemic racism in society and how it might spill over into medicine, so-called racialized medicine that may result in clinical constructs that do harm to communities of color. And so over the past year, one particular example has come to the fore in the kidney community. Multiple academic medical centers have removed the race coefficient for estimating kidney performance out of a concern for bias and purported differential access to specialized kidney services. So examples of racialized medicine, you can look to the publication of Vias, Eisenstein and Jones. Hidden in Plain Sight is published in the New England Journal in August of 2020 as many different clinical algorithms that have a race correction that may operate to actually promote disparities in a number of healthcare services. Returning to the kidney function assessment and estimated GFR, 90% of US clinical laboratories report an estimated glomerular filtration rate. This is the kidney performance metric when serum creatinine is measured. The current estimated GFR equations use a race correction, and that's correct based on categorization of race of Black versus non-Black, really a bifurcated categorization that's actually quite gross, based on a large set of cohort studies that indicated a higher average serum creatinine concentration for the same measured GFR level in Black versus non-Black, predominantly white individuals. And those studies were the modification of diet and renal disease, MDRD, and the chronic kidney disease epidemiology collaboration, CKD-EPI, which used iothalamate radioisotopic GFR as the gold standard measure of GFR. In MDRD and CKD-EPI, MDRD reports a higher estimated GFR by a factor of about 1.21, a 20% increase relative GFR relative to whites. And CKD-EPI, which included a larger number of Black patients in the study population, proposed a more modest race correction by a factor of about 1.159, a 16% increase. And the equity concern here is that both equations report a higher estimated GFR when the patient is identified as Black, suggesting better kidney function in that individual. A clear biological explanation for this association has been lacking. The references to increased muscle mass as a generation of creatinine from creatine compared to other racial groups, that's based on studies and publications from the 1960s and 1970s. In addition, the process for determining ethnicity for MDRD was by examination of skin color, and for CKD-EPI, self-reported race. These are really fairly rudimentary constructs to identify true racial differences. So the hypothesis has been that the assignment of African Americans to the less severe CKD stage due to a race multiplier in estimated GFR equations may contribute to and exacerbate healthcare disparities in end-stage renal disease and transplant care. I'm going to show you how that works. The inclusion of race in the calculation of estimated GFR overestimates kidney performance in Black patients. So here's are some clinical examples. This is from the OPTN in orange, the URL, looking at the kidney disease risk index. It estimates the predicted risk of donor kidney graft failure, used to predict the viability of potential kidney donors. And you can see the input variables here are donor disease, hypertension or diabetes, terminal serum creatinine, if the patient was a donor after cardiac death, and so forth. And for race, African American. The use of race in the KDPI increases the predicted risk of kidney graft failure if the potential donor was identified as African American. And so the equity concern here is that the use of this tool may reduce the already smaller pool of African American kidney donors in the United States. In addition, the variable assigns an estimate to all African Americans as a homogeneous cohort, and that's clearly a biological miscalculation. So clinical application, let me give you a couple examples here. So one is preemptive listing for transplant. And this is a work that we did with Peter Rees and Amaka Inanya at the University of Pennsylvania, looking at racial disparities in preemptive waitlisting and deceased donor kidney transplant. And what you see here is the rationale for this query. First off, what's the whole idea of preemptive transplant? Why is it something to be concerned about? Well, there are advantages here. This is an unadjusted analysis of about 60,000 deceased donor kidneys by dialysis vintage, done by Meyer Kresge. What you see here on the y-axis here is event-free survival. If you have a preemptive transplant, that is, if you were transplanted before going on dialysis, your event-free survival is much higher than even if you had 0 to 6 months of transplant, or 6 to 12, 12 to 24, and beyond 2 years. So preemptive transplantation is a real advantage in terms of post-transplant survival. 20 years ago, Kosisky reported that Black patients were much less likely to receive preemptive kidney transplants, and that we providers would have to redouble our efforts to make sure that this inequity wouldn't be durable. So policy changes needed to be in effect, but in fact, in 2014, the kidney allocation system changed. There were no changes to the system that might mitigate this particular disparity in transplantation. In 2019, therefore, 11% of all adult deceased donor kidneys were preemptive. White patients received 65% of those allografts, and Black patients received only 17%. And this is during a year when the wait list was comprised of 38% white patients and 31% Black transplant recipient candidates. And the next figure shows persistent racial disparities in preemptive kidney transplantation over time. And you can see now over this 15-year period thereabouts that in white patients in blue here have really a substantial increased rate of preemptive transplantation as compared to ethnic minorities, Black patients in green here. So wrapping up my segment of the presentation, there are a number of diverse barriers. For example, for this example, preemptive waitlisting and deceased donor kidney transplantation in the United States. And this slide really sort of highlights many of the tiered barriers that Arnie Epstein and coworkers were getting back, were writing about 20 years ago. There are patient level barriers in terms of for individuals with chronic kidney disease. There are provider level barriers for nephrologists and primary care doctors and other providers, trans-semantic center variables, and so forth. And so for patients, limited education and resources to navigate a relatively complex healthcare system, low health literacy is a continued problem with that. A lack of understanding the urgency for renal replacement therapy and for transplant evaluation. And then again, I showed you that poor insurance products, less robust insurance support may be an impediment. At the provider level, there may be limited provider availability, a lack of understanding of the urgency for renal replacement therapy, and then there may even be clinician and structural racism that plays a role in a lack of accommodation for challenges faced by minority patients. At the transplant center level, again, insurance barriers to transplant center access, the so-called green screen. And then I talked about how the race coefficient itself assigns Black patients a higher estimated GFR. So that may be an impediment to early referral. And then there may be a more rapid estimated GFR decline among Blacks and other groups that allows less time to complete waitlisting steps before renal replacement therapy. So these barriers all operate, for example, in the preemptive model, that it's a first come, first served. Those are usually white patients, favoring patients who get to the wait list earlier and prior to dialysis, or even if they're not dialyzed, they begin to accrue dialysis waiting time on the wait list at an earlier stage. So in summary of this section, GFR equations use Black race to achieve slightly better statistical precision in estimating kidney performance on the population level. The net effect is that compared to white patients with the same age, sex, and serum creatinine, Black patients are estimated to have higher GFRs. There's no real understandable biological basis for this, and there's more work actually ongoing as we speak on this very question. And in a large summary, African-American CKD patients have poor outcomes with respect to, for example, anemia and hypertension management, timely nephrology referral, or timely preparation for end-stage renal disease replacement, dialysis, fistula, AV graft, fistula placement, adequate dialysis treatment, and access to transplantation. And I've touched on a number of barriers to access and actual implementation of transplantation as we reviewed over the past 15 or so minutes. So I think that's my last slide, and thank you very much for your attention.
So Wynn, thank you very much. That was a truly excellent summary of many of the factors that are sort of playing in this space. And I'd like to ask all of the panelists to open their video screen and unmute themselves. And I think, what we would like to do now is go into sort of a panel discussion, and I'd like to invite the other panelists to comment or contribute to some of the points that you raised in your talk. And I will, maybe start by asking a question or asking for clarification, for the audience, to ask you, you showed very striking rates of increased kidney failure amongst African-American patients. And not everybody may be aware as to what the causal factors may be. And I don't know if you wanted to elaborate on that.
Sure. No, I think part of the answer to that has to do with genetic modifiers that might increase or portend risk for kidney failure in Blacks, and especially in African Americans. And this is a function of the discovery with Martin Pollock and colleagues of the G1 and G2 variation around the gene ApoL1. This is a gene that came to high genetic frequency in sub-Saharan Africa as a protection against African sleeping sickness, because it conferred resistance to trypanosomiasis. And those variants were carried forth in the slave migration to the United States, such that, again, about 10 to 13% of African Americans actually carry these genetic variants forward. And they do, if you have 2 copies of the gene, enhance your risk for developing CKD. Not all patients, but many patients actually are genotype positive for this genetic risk factor. And so that's an ancestral marker that's really been discovered in the past 5 to 7 years that helps explain some of the biology as to why there's a disproportionate rate of kidney disease in Blacks in this country.
Thank you. So I was going to open it up to the other panelists if they have any comments or questions for Dr. Williams.
Now, this is Edgar. There are a couple of other issues which you touched on, one of which is that clinicians may have African-American patients start dialysis later, partially because of this notion that their GFR is higher, but also because of the general care and frequency and follow-up of African-Americans being lower.
Yes.
Secondly, I believe that the waiting time in the current system starts when you go on dialysis. So in terms of allocation, one of the strong positive things about waiting time is that it gives you a higher position on the list. And if you're not dialyzed, the waiting time starts at the moment when you're dialyzed. And the last thing is that I believe that there are 2 aspects to allocation. One is the quality of the donor, which is a score between 0 and 100, the higher numbers being worse, let's say above 80. And then, but there's also an evaluation of the candidate and whether or not that candidate is going to, on average, accept an average donor kidney. And I believe that race is one of the factors that's put into the recipient or candidate risk factor. Is that true, Wynn?
Yes, it is. I think there's there are more than a few points there, Edgar. Actually, if you have a GFR that's that falls to 20 cc's per minute as a threshold, even before dialysis, if you come to a center for attention and have been evaluated as a reasonable transplant candidate, your waiting time begins to accrue right then and there, even before beginning dialysis. But you're right, you're guaranteed waiting time from the start of dialysis initiation. You're right too that it's not only a donor a KDPI risk calculation, but post-transplant, the post-transplant estimated time for survival post-transplantation is also calculated. And risk does play a role in that calculation.
Great, thanks. So I was going to open it up to other panelists, Dr. Cattleberry or Dr. Tucker. Do you have questions for Dr. Williams or?
Yeah, hi. One of the things that has always been striking to me is that even though we know that patients can gain time from the time they start dialysis, we're still seeing an increase in at least a significant number of patients coming forth now to be listed for transplant, having been sitting on dialysis 5, 6, 8 years. And so we know that time on dialysis, or the number of years you sit on dialysis, also increases the mortality and how they do post-transplant. So, I've always been bothered by the fact that there are these patients who are sitting out there and maybe weren't candidates or are now being referred late. And how do you account for these latecomers who are now coming forth to be listed for transplantation with many years on dialysis and now can at least gain extra points to be transplanted sooner?
Well, I've just answered that. I think a lot of that's provider education. Patients have to be referred. And the part of the CMS directives now is that once you begin dialysis, that in fact, you've got to check a box whether in fact transplantation has been considered as a best practice replacement therapy, and all candidates should have an opportunity to be evaluated. If you don't get referred and you're not sort of your own self-advocate, you don't get seen and you don't get the benefit of a transplant evaluation. So a lot of this is provider education to make sure that patients are timely referred. The only benefit to patients who have stayed on the list for very extended periods of time is that they do get waitlisting points. And so once they do get evaluated, they really rise fairly quickly to the top of the waiting list, and they do enjoy the opportunity for transplantation on that basis. And in fact, in 2014, when the kidney allocation system was changed, there was a bolus effect for those patients who've been waiting on dialysis for many, many years. All of a sudden now, a huge swath of them were transplanted immediately because of the change in the allocation system.
Wynn, thank you for a very illuminating presentation. Would you just explain to our audience, what do you think is actually contributes more to the excess risk of kidney disease in patients of color? Genetic and biologic factors, or more of the social determinants of health?
That is a great question, Kevin, and it's a hard question because we know that there is a increased risk that's been identified if you're homozygous for these genetic variants that I mentioned. But not all patients who are homozygous, in fact, have CKD and progress to end stage. I think a lot hinges too on social determinants of health, access to high quality primary care, and really dealing with diabetes and hypertension, which are the predominant diagnoses for patients coming to end stage renal disease in the United States. If you have poor primary care, if you have poor health outcomes on those metrics, then you're at increased risk for untoward kidney effects, basically because you're not getting the kind of best practices that are necessary to take care of those disease entities. So I think it's a combination of both environmental and access to best resources. Our patients live in communities, if they're socioeconomically disadvantaged, that have a range of problems in terms of not only health literacy, but a whole range of other environmental risks that they have to contend with. But there's clearly a biological component to this. Weighting which is more predominant, I think, is still, the jury's still out on that.
When the one health problem in the United States, one that I personally suffer from, is obesity. And obesity is endemic to all communities in the United States, but African American and also Hispanic communities, and very much so Native American communities, have this problem, you know, even from childhood.
Yeah.
Could you make a comment about the risks of obesity in terms of the increase in kidney failure?
Yeah, no, I think that's a very important point, Edgar. So obesity in and of itself, after a certain point, can drive kidney insufficiency and changes in the kidney performance in and of itself. But obesity in the United States is usually associated with diabetes and hypertension. And again, as I mentioned, diabetes and hypertension are the predominant diagnoses that bring people to chronic kidney disease and progress to end-stage renal disease. I think if you look at communities that are where obesity is endemic, these are communities where there are food deserts, where there's not access to high quality, high caliber food services, not access to high caliber groceries, where there's only a very sort of high calorie fast food available. And again, it's a part of an environmental challenge for such communities. And so those kinds of food disparities lead to increasing rates of high caloric intake, high salt consumption, and then that drives hypertension and diabetes. And so I think until we really get at unearth and manage some of these environmental factors, many communities, especially communities of color and vulnerable communities, are subject to these disease entities that drive kidney disease.
And just one last point, most transplant centers have these cutoffs in terms of candidates and accepting a candidate who may be obese. They may say, oh, you're obese, we cannot put you on the list. What is the risk of obesity in terms of your transplant survival, and are the levels appropriate, and do they disadvantage African Americans?
Yeah, there's a debate there, and Velma might really comment. You know, so there's a high rate of surgical misadventure and complication in patients who are morbidly obese. And so if you have a BMI that's north of 35, pushing 40, those patients are in a category where they have a higher rate of post-surgical complications. There is work being done now to try and figure out whether in fact that should be an absolute contraindication to transplantation. It may not be, but there are programs now, including at Mass General Brigham, where patients are being referred to obesity centers to look at the idea that perhaps preemptively, again, prior to transplantation, certain patients should be candidates for gastric bypass or some gastric manipulation that might enhance weight reduction and then enhance their candidacy. So that's another strategy. But in general, I think the teaching has been that if you're morbidly obese, above a BMI in the 40 range, you're a poor surgical candidate because of postoperative complications. I know, Velma, do you want to comment on that?
Yeah, absolutely. I think, you know, more and more the BMI limit has gone upward in terms of their programs who will accept a BMI of 40. Others will cut off and say, well, you know, 45, but absolutely over 45 or definitely over 50 refer to your possibility of having a gastric bypass prior to transplant to augment your ability to do better. But one of the things that we always have to take into consideration is the distribution, the body distribution is important. So rather than cutting someone off because the BMI is 38 or 40, sometimes that distribution, body distribution is not going to contribute to surgical complications or difficulty placing that kidney graft because of the abdominal area may not be the problem. And so there are programs who will assess the patient as you may have a football player who may have a BMI of 42, but he's not, even though he's over the range, his distribution may not be prohibitive. So those things, we should not just have a cutoff without allowing the patient, seeing the patient and coming up with strategies to say whether or not this will interfere with transplantation based on the complications or even the size and a disproportionate outcome based on kidney size of the donor versus the recipient, those sort of things, and longevity.
So, I'd like to make a comment here because I think that's a very important comment. And, the standardization of what counts as, being overweight or having, poorer outcomes because of weight issues is very much normalized to certain populations. So, for example, the outcomes for BMIs, increased BMIs, does not really correlate with outcomes in South Asians, for example. It's more to do with waist size than it is to do with BMI. So I think there has to be a consideration of the individual patient, as you said. And, unfortunately for everybody, our next Kidney Crossroads is going to be exactly about, weight and kidney disease. Because I think now there are many different strategies, not just bariatric surgery. And I think the point is that outcomes for patients, even before they get to transplantation, are improved if BMIs are reduced. So there is a benefit that goes beyond just getting somebody ready to be transplanted. So I actually want to change tacks a little bit here, and I wanted to ask Dr. Tucker about his views on the utilization of home therapies for patients with kidney failure.
Well, thank you, Anil, for that question. I think that Dr. Williams, in his presentation, outlined the fact that home therapies, and by that we mean home peritoneal dialysis and home hemodialysis, tend to be underutilized in patients of color. And I don't think that we fully understand the reasons that home therapies are underutilized. I have a few theories. And one is certainly our own biases about which patients are candidates for home therapies. I think that too often clinicians make assumptions about who can do home therapies that really are not based in facts about what it takes to do home-based dialysis. And home-based dialysis offers many advantages. We saw during the COVID epidemic that individuals who didn't have to go into a center, one, they weren't exposed to other patients during the pandemic. They didn't have to worry about transportation. In a climate like Boston, where we have winter snowstorms, patients don't have to worry about their transportation to and from the clinic during a snowstorm. Furthermore, at the biologic level, we know that patients who do particularly home peritoneal dialysis maintain their residual renal function longer, and maintaining residual renal function may confer a survival advantage in and of itself. So I think that we're depriving our patients of not only a therapy that has many advantages socially, but may have some advantages medically as well. Finally, the ability to maintain independence, to maintain a working lifestyle also is advantageous to our kidney patients. And I think we should be encouraging patients to maintain their ability to work as much as possible. And so I think we ought to be promoting home therapies for all of our patients and making sure that we're not systematically excluding patients from communities of color from those home therapies. When I talk to many of the patients who are admitted here at the hospital and ask them, did your nephrologist talk to you about home-based dialysis before you were placed on intensive care hemodialysis? And if the patient is a patient of color, overwhelmingly the answer is no. So I think we have to ask the question, why are patients of color not being educated about home therapies and being offered it? And I think some of it has to do with clinician bias about who is and who is not candidate for home-based therapy.
Thank you, Kevin. So I'm going to switch to some of the questions that we're getting in from our audience. And there's a question about how can we increase the number of organs used for living donation amongst the Black community. I know, Dr. Cattleberry, you did work in this area, and I want to see if you have any comments about this.
Yeah, thank you so much. Constantly there's continued need for education about living donation within our communities, but particularly within communities of color, in terms of trying to get our communities to understand, as there's a lot of misperceptions about organ donation, both deceased and living donation. And so that's a continued area of focus and outreach and education, because getting into the communities, answering their questions about why there's a reluctance to donate, besides the distrust of the medical community. The other issues we find is that even within African Americans, as they may have consider living donation, generally they're looking within their family members, and oftentimes if their diagnosis is high blood pressure, diabetes, they're unable to find an appropriate donor because they're also thinking related. I don't have any relatives that who can donate. And so getting them to understand that you can go, that is no longer necessarily living related, and that there you can look beyond that. And so strategies for better education, outreach beyond the transplant center, getting out there with boots on the ground to begin to talk more about living donation and benefits of living donation. And as Dr. Tugger said, even to present these ideas before they get to dialysis, as oftentimes those options may not even be discussed prior to hitting dialysis, as they may be diagnosed late, and therefore lack of early or interventional preemptive transplantation. But understanding they definitely, as I continue to talk to patients, is a need to understand, why are you afraid? Let's talk about why you're reluctant, both to sign your organ donor card and even to say, I'm not asking anyone in my family to donate. So those are conversations that need to be had and continue we continue to do them so we can increase organ donation.
Thank you. And I think, this is just a general question to the panelists, that there are a lot of questions coming in from the audience, which really are around this idea. Well, people are really shocked, right, that the rate of kidney disease is so much higher amongst African Americans. And I think there's a lot to be done to educate our audience, our patients, our colleagues, in terms of what the actual facts are, what things we can do to improve it, and how do we increase both deceased and living donation. And I know one of the things I think I was going to ask Dr. Milford, as the director of the tissue typing laboratory, that there are certain things that are done to try to alter the balance of organs that are distributed from deceased donors, like the ability of blood group B patients to receive blood group A2 donors. And I don't know if you wanted to talk a little bit about that, Edgar.
Yes, I mean, historically, there have been certain blood groups that are more predominant in Blacks. And over the last 20, I would say, years, people have tried to either relax the requirements for blood group matching with evidence that is okay to do, or give priority to certain blood groups when the probability of your getting an organ is low if you try to match. So without going into all the detail about the specifics of that, let's say that for blood group matching, people have tried to adjust the system so it gives a handicap to people who otherwise would have a very low probability of getting a match for blood group. Now, for HLA, which is what I thought you were going to say, as you know, people have historically tried to match the HLA of the donor with the recipient. And the difficulty is that when you really try to do that in a perfect way, what you find is that the only people, not the only people, but very largely the people who can get a perfect match are going to be Caucasians, okay? And that has to do with a lot of things, including the fact that Caucasian HLA types are much more restricted. So there are fewer of those HLA types. Therefore, within the Caucasian community, it's more likely to find a match with another Caucasian. And the other side to that is that among people with African descent, there's about a 10-fold increase in the variety of HLA types that you might have. So it's much more difficult to find a perfect match among African Americans. So if you have an allocation system that puts too much emphasis on HLA matching, even though HLA matching is a good thing, you will distort the system to the disadvantage of African Americans.
Right, and that's not to say that the rates of donation amongst the African American community is less for deceased donors, is actually, I believe, higher than
It's at least equal, yes. Now,
so it's not based on pure numbers.
Neil, may I ask a question of all of you, since I'm the only non-transplant nephrologist in the crowd, but it seems that one of the barriers to preemptive transplantation is that in a given family of African descent, there's so much hypertension and diabetes. Are there efforts to try to discriminate more clearly as to which individuals are likely to develop kidney disease and therefore should be excluded as donors versus those who are at low risk and consider them as donors? This came up in a family Zoom call where we're talking about a family member who needs a kidney, and everyone on the call, even those who were not overweight and in otherwise good health, had either hypertension or diabetes. So are there efforts to try to further define who's at risk for developing kidney disease and should be excluded as a donor, so we might expand the pool of potential donors from families?
Dr. Williams, I'll let you have the first crack at that.
No, I think it's a great question, Kevin. So the answer is yes. There are efforts afoot. A lot of this has to do with a large scale effort called Apollo to actually do genetic mapping of families to see if, in fact, some of the risk variants we talked about earlier are present in families, because often sort of the genetic predisposed evidence was that if you have one family member with kidney disease in a Black family, you might find the uncle and the aunt and other family sisters and brothers also have or early CKD, and there may be a genetic basis for that. So there's an effort afoot to genotype donors and recipients and see if, in fact, families have a predominance of these gene variants that might confer risk. The other thing is that in patients who in families have higher rates of diabetes and hypertension, those donors have to be really very carefully screened. And so we look at all indicators of potential kidney disease and urinary protein excretion and such, blood pressure levels and such. Patients who have very, difficult to control blood pressure or some, for example, urinary chemical evidence of kidney disease are excluded as donors. But I would say this, I think it's a very good question as to who represents a safe risk in a family that, for example, is African-American, where there may be multiple family members with kidney disease. It's a difficult question. Genotyping may help clarify some of it.
So, I'm actually just looking at the clock and we're just about to finish our time. So I apologize to people who've asked questions that we haven't answered. We're going to try and answer them offline. I'd like to really at this juncture thank all of our speakers. This is a great discussion. I wish we had another hour or two to discuss these issues, because I think there's a lot of important issues to discuss here. I'd like to thank the sponsors of this event and the attendees. And I'd like to thank Stacy Sennett from the National Kidney Foundation. She's worked very hard to put this together. This is a joint program between National Kidney Foundation and the Brigham Williams Hospital. I think it really provides a novel opportunity for us as physicians to interact with our patients, and we really appreciate that. And I hope that you'll all join us for our next Kidney Crossroads, which will be sometime in May. And as I said previously, it will be to do with weight and transplantation. Thank you very much, everybody.
Thank you all.
Thank you.
thank you.